Yes, Ms. Scott.
Dr. Boulton, I'm going to move on now to ask you some questions about your knowledge of risk of hepatitis. Is it right to understand that you have known since you started practice that there was a risk of hepatitis B being transmitted by blood and blood products?
From the start of my practice, not quite sure when to define that, but certainly as students we were taught about serum homologous hepatitis, the fact there are two sorts of hepatitis, which became known as A and B, and the B was the homologous serum hepatitis that could be transmitted by, for example, injections using shared needles, as in vaccinations, for example. And as my training proceeded, we got more specifically aware. And while I was senior registrar at the London Hospital, I spent 5 months at the Brentwood Transfusion Centre, which is where I first learned specifically about the tests for the hepatitis B surface antigen, which was still known then as Australia antigen, had been known about 10 years. But the testing was introduced for blood donors in the early 1970s, and I was actually taught by the scientists who performed those assays how to do them back in about 1972.
And is it also right to understand that from the time that you were at the Royal London, that you understood that the screening process did not screen out all cases of hepatitis B?
I obviously learnt from the experience I recounted earlier that there was more than one form of serum hepatitis. So that, in a sense, one was not surprised to hear that others were aware of this particular situation. Dr. Krask in Manchester in particular was very helpful in improving my understanding of that situation. So yes, from the early 1970s, we were aware that not only was there other forms of infectious hepatitis like hepatitis A, but other forms of hepatitis that could be transmitted by, quotes, serum, which included B, but then other forms which initially were called non-A, non-B.
And that the screening processes for hepatitis B didn't pick up all of the hepatitis B infections. Some of them still.
Yes, that's also true. Yes, that's also true. Hepatitis B is a strange virus in that it has the habit in most people it infects of going through a phase of vast overproduction of this protein called the surface antigen, which is the protein on the surface of the hepatitis B virus. But it has a propensity in most people to overproduce that, and it makes it very obvious. So it's easy to detect a person, most people, who are at the stage of carrying hepatitis B virus, either because they've been acutely infected or because they're one of the minority who become a chronic carrier. And the chronic carrier state is quite important to us in transfusion, because those are people who are entirely healthy, well, asymptomatic, but do transmit the infection. So we were aware that hepatitis B was an extraordinary virus, easy to detect, but not always foolproof. There were some people who infected did not exhibit this particular overproduction phenomenon, and also sometimes the carriers would go through phases with very low production of surface antigen. So it would still be quite possible for someone to test negative with those tests, but still actually be infectious. And we knew that.
And you tell us in your statement that you understood from very early on in your career the importance of pool size in determining the infectivity or potential infectivity of a blood product. Is that right?
Absolutely, yes. There was some excellent early work done in the war. And actually, I've also just seen a paper that came out in 1949 by Dr. Lahan, who became the director of the Liverpool Centre, which also indicated the impact of pooling. And in those days, they called large pools of the order of 300 donations in a pool, which is which is very much smaller than the pools that we became more familiar with in the preparation of factor VIII concentrates.
So is it fair to say that you have always known that there is a risk of getting a transfusion-transmitted infection from concentrate, and that risk was significant?
Yes, that was well recognised by not only myself but all my colleagues. But and you may be coming on to this, the consensus of opinion in the 1970s among haemophilia doctors, and indeed among many other physicians, was that the non-A, non-B form of hepatitis was often mild, even asymptomatic, and people might get an infection from it, but only be slightly ill, if ill at all, and in time would completely recover. It was that complete recovery that in the end came to back to bite us, because we obviously learned in time that most people with non-A, non-B hepatitis that became labeled as hepatitis C were still affected for the rest of their lives, and their livers gradually deteriorated.
And just for the transcript, you mentioned some work that came out in the war that relating to pool size. I think you might have been referring to the work of Dr. Vaughan in 1946, and the transcript for that is RLIT 5052. I'm afraid I don't have the transcript reference for the Lahan article that you.
No, that was very recent. I can send that.
As I understand your evidence, you were aware, were you, of the publication of Professor Preston's study in the Lancet in 1978, in which he had carried out biopsies on asymptomatic people with haemophilia and discovered a wide range of quite serious liver disease? You're nodding.
Yes, I will. Yeah, I mean, that was a remarkable piece of work that was received in some quarters, including myself, with some incredulity at first. Partly because I think there was a sort of wishful thinking, partly because there were some criticisms about, well, many of his patients, and there were 8 biopsied, were middle-aged men, and there are lots of causes for cirrhosis in middle-aged men, particularly alcohol. So there was a certain amount of skepticism, which on reflection was completely unjustified, because that's an incredibly bold piece of work. There was also, I know these things shouldn't happen to the clear-cut academic mind, but nevertheless, there was some reason to note the irony of the need to insert large needles through the skin into people's livers in order to get a bit of tissue. And if you do that to anybody, they will bleed. And if you've got a haemophilic there, then of course they will bleed even more. But Eric took the precaution of transfusing them with factor VIII, and I don't know where it came from, but I wouldn't be surprised if some of it was commercial, to raise the activity of factor VIII in those patients' plasma to normality 100%. And that's a lot of factor VIII. You had to give 3,000 to 4,000 units, and it only lasts for about 12 hours. It starts deteriorating immediately. So he was giving the very materials that were potentially causing the problem to people with by doing the liver biopsy. And so there was a sort of atmosphere of incredulity about the whole thing. But Eric is a very fine scientist, as is the tradition from Sheffield anyway. And we should have taken more notice of that. We still rather hope that even if there were cirrhosis, if the people were asymptomatic and leading normal lives, they were the actual clinical consequences would not be quite so severe as the biopsies indicated. It's a classical case of looking at the patient, seeing how they are, and then noting what the laboratory investigations say without necessarily linking the two. So a bit of self-denial among the haemophilia doctors community, and I include myself in that. And we were wrong. There's little doubt of that.
And when you say you should have taken more notice of that paper, are you referring there to amending your prescribing practice to turn away from factor concentrates back towards cryoprecipitate?
There was a lot of talk, not so much then, but I think in the early 80s, and particularly with the onset of HIV/AIDS, that these infections, these diseases that were caused by infections in the factors that were being transfused to these people, should have made us think more than twice about expanding the use of those concentrates. But the power of persuasion of those who witnessed, and that's not just the families, but the doctors, who witnessed the instantaneous relief of the suffering that could be that did follow the treatment of the hemophilic bleeding episode with these concentrates. This was miraculous. I mean, hemophilics before the 1960s had to lead an extraordinarily limited life. They were crippled and their life expectancy was short. And I think others to the inquiry have given witness to that. And certainly those hemophilics who I saw as a student at St. Thomas's were brave young men already incredibly disabled. So the prospect of being able to reduce or even prevent that degree of crippling by a relatively simple procedure of intravenous injection that people could learn, sometimes even the patients themselves could learn, offered a bright future for these young men. And the persuasive power of that image, it wasn't just an image, it was direct experience of the, not just of the patients, but of those treating the hemophilics, was very, if I can put it that way, seductive. So we felt as a community that it would be wrong to radically alter the approach. There were stages when people thought about reducing it a bit and reducing the commercial doses a bit and improving the cryoprecipitate a bit. But actually, these were quite difficult to enact on a large scale.
Would you agree as a matter of principle that patients being treated with factor concentrates should have been told that a risk of that treatment was contracting non-A, non-B hepatitis when you were practicing in Liverpool?
Yes, that is a fundamental principle. And to my recollection, we did, as doctors, try to, well, we did not deny, and we actually did assert at opportunities that there was a risk of infection in the materials. But in the late 1970s, even after Eric's paper, which is why I say we should learn more, there was still a feeling that that risk was acceptable because the infection symptoms were short-lived, and as far as we could see, the long-term effects were minimal. So consequently, the short-term disadvantage of a short period of relatively mild jaundice, although some actually became quite ill, that short-term effect was outweighed by the long-term benefits of not being disabled as their predecessors had been. So I think we did tell patients and their families, but we almost certainly underplayed it. I can certainly remember speaking to the haemophilics in Liverpool in the newly formed branch of the Hemophilia Society about the prospects of treatment, and the patients were excited about the possibility of leading a life like diabetics who were injecting themselves every day with insulin. And I sort of acknowledged the validity of that aspiration, and I think others may need to be asked about this, but my recollection is I did say that little bit of a but. There is a risk associated with every injection, and that could include infection. So, but almost certainly, in fact, I'm sure I did underplay that particular risk. And so the good news suppressed the bad news in practically everybody's mind.
So just unpacking some of what you've said there, is it right to understand that the primary way of patients being informed of risk from treatment came through contact with the Hemophilia Society, rather than being told on a one-to-one basis when they were getting their treatment from you as their clinician?
I think it was both. It so happened that the Hemophilia Society branch in Liverpool, the setting of that was encouraged by myself, but not every haemophilic attended meetings of those societies, so consequently it would have been quite easy for them to have missed information. So it was encouraged on us to actually inform every patient that there was a risk. But how well that was done, I have doubts. I think it was probably, the message was transmitted by me rather inadequately in retrospect, looking at what we now know.
And you've said that you almost certainly underplayed it, and you've used the word inadequate. Why was that? Why was that approach taken?
Well, as I said earlier, it's because the visible benefits and the relief of suffering that these concentrates were able to produce seemed so much greater than the apparently minor adverse reaction of suffering from a short-term burst of hepatitis. So we got the balance wrong. So basically, as I said, the good news suppressed the understanding of the bad news.
And were your patients subject to liver function tests at appointments?
No, I don't think they were, not as a routine. If they showed signs of jaundice, then they would have been conducted, but not as a routine.
And if you suspected that a patient had been infected with non-A, non-B, would it have been your practice to tell them that?
Or indeed with hepatitis B, yes.
Well, with hepatitis, yes. So you would have, if you'd got abnormal liver function test results back and suspected non-A, non-B, you would have told the patient that. That was your practice.
Well, I think it worked like we had regular follow-up clinics. So roughly every 3-6 months or so for an individual haemophilic. So they would come. We would ask, how are you getting on? How are you managing home therapy, etc. And they would answer. And if among that, if in that conversation there was apparently, I felt a bit ill, felt a bit funny the other day or last week. At that point, we might do include tests of liver function for those patients. And if they were abnormal, we would test further specifically for hepatitis B, because that test was available. Obviously, no test available for hepatitis C, wasn't even called that then. So the combination of disordered liver function and hepatitis B was certainly worth passing on. And I imagine that we did so. But I have no recollection of precise conversations of that nature in the clinics. But that's what the follow-up clinics were for, to check not only how they were coping with the haemophilia, but how they were, what their general state of health was. So there were ways in which we could be informed, but we did not regularly conduct liver. I don't think we conducted liver function tests on patients at every clinic that they came to.
And would you accept as a matter of principle that if you had made a diagnosis of non-A, non-B, to the extent that it could be made, a diagnosis could be made given the limitations, would you accept as a matter of principle that the patient should have been told?
Yes.
And do you have any recollection of giving advice to patients about lifestyle and infecting others if you had made a diagnosis of non-A, non-B?
Which would include reference to their sex lives, for example.
Indeed, precisely.
I think probably not on a regular basis. I mean, the attitudes to those personal lifestyle matters were very much more constrained in those days, although obviously people working in, the staff working in sexually transmitted disease clinics would have a very different take. But I think, and particularly with mothers and young children, we would not really be referring very much to those lifestyle aspects. And certainly in Liverpool, the attitude towards those lifestyle factors, and including injecting drug use, and by the way, it's much better to use the term injecting drug use than intravenous, because some drug users don't intravenous, but they actually do it by percutaneous injection. But we rarely, if ever, touched in any detail on that aspect of the lifestyles of the haemophilics and their families back in the 1970s.
In your statement, you have suggested that some information was given about the risk of needle stick injury, for example, for a patient that had hepatic illness or hepatic virus. But you say that you had no evidence to suggest that the parents, when you were giving this information, understood the risks that understood what you were getting at. I paraphrase, but can you tell us a little bit more about that?
I think so. I think I can. I'm not sure if the risk of infection was specifically identified. So in other words, when training a mother how to inject her son, we would have said, take care about these needles, because they're sharp. That's why you have to be careful about your technique of injecting your child. But I'm not sure if the specific risk of hepatitis transmission from the contents that they were injecting, how much that was emphasized. But clearly, the risk was that the concentrate was reconstituted in water at home, taken up into the syringe through the needle. So that needle was obviously then, it contained the therapeutic materials. It was then injected into the child. And if in the meantime, a mishap occurred and the mum scratched herself with that needle while giving the injection, that was an undesirable event. Whether I stressed that the undesirability was as much to do with the contents of the vial being at risk and how much it was due just to the undesirability of an unfortunate accident like that in general, you don't want to hurt yourself unnecessarily, I cannot really accurately recount. So it may well be that the mums didn't really understand, excuse me using that phrase, but the parents giving the injection didn't really understand that the risk was in the materials they were giving. They were much more concerned about the benefits from the materials they were giving, and the risks was sort of put in the background. And probably my training schemes didn't emphasize that aspect to them as much as probably it should have done. So that's the way it went. As time went on, we learned much more about how to deal with these things. But that was a difficult phase at that particular time in the 70s when home therapy was expanding, and because the benefits were so obvious and the disadvantages were much more obscure.
And were referrals made to hepatologists for those that had a diagnosis of hepatitis B and a diagnosis of non-A, non-B?
When the patients who developed jaundice, whether it was identified as hepatitis B related or not, would have been seen by a physician, referred to in the hospitals, both in the children's hospital and in the adult hospital. But actually, it was really quite rare. I mean, there were a few, as you will see from the tables, about up to 6 different people, although sometimes there was some double counting, who in my time did develop clinical jaundice. And they would not only have had their liver function test determined, but they would have been referred to a physician, but and also their GPs informed. But I honestly cannot remember specific episodes of such referrals.
What role, you touched on this to an extent, the role that patients had in choosing their treatment at the time that you were in Liverpool? I think you said they didn't get a choice between NHS concentrate and commercial concentrate, but you, as I understood what you were saying, if they had a preference for a particular type of commercial, that may have, they may have had a say in whether they wanted a particular type of commercial if they found one easier to use than another. Is that a fair assessment of fair summary of what you have said about the treatment?
It may be a slight over-interpretation because all these things come from a memory which is of events of more than 40 years ago. But I do remember conversations, not least at the meetings of the Hemophilia Society group which I met, discussions about the problems and the choices that they had of giving factor VIII concentrates. I think all of them would have preferred the NHS had that been available. But even in 1979, even though there was a considerable increase in the productivity from the BPL laboratories, there was still it was still in short supply. So I think in many cases they just had to accept what was made available to them. So there wasn't that much choice about it, although there could well have been preferences.
And would you agree, excuse me, would you agree as a matter of general principle that treatment decisions for patients involved weighing up the risks and benefits of one product against another?
Among the commercials, I don't think there was much differentiation. But I think people on principle would have probably preferred the NHS had that been available in the quantities that were required. So I think the dividing line in choices would have been between NHS concentrate and any of the commercials, the latter being given roughly the same degree of acceptance compared with the rather greater desirability of the NHS concentrates, for reasons which they understood on terms of pool sizes and where the materials came from. In other words, often North America for the commercial stuff, but only British people, people donating in Britain for the NHS concentrate.
And they knew the difference in the risks between the NHS commercial and the NHS and the commercial because you had told them that, or because it was generally well known amongst the haemophilia
I think it was generally well known among the haemophilia community, but because probably out of a sense of, as much as anything else, of national loyalty to what the NHS was able to do. So if the NHS was able to produce something that worked compared with a commercial company that was being paid, then ideologically, everybody, including the patients, would have preferred the NHS, but it was a sort of ill-defined as that. When it actually came to the hard facts, data, that here was something that could save your life, stop your bleeding, and save your life, stop you from bleeding death, there was a sort of more pragmatic approach about what they wanted was something that worked, rather than where it came from. Now, I have to emphasize that these are recollections and impressions and what I, in a sense, would like to think I would have done under those circumstances. It may well be that my performance, had anybody been around to witness it and document it accurately at that time, was not up to the ideals, which I have perhaps currently said. So I do have to point out that the ideology, which we've all been able to develop since, may not have been fulfilled quite so much in practice, in my practice, for the haemophilic communities in the late 1970s.
I've just got one more topic to ask you about before we move on to your time in Edinburgh, and that's record keeping. What was the system for recording products received and batches used? Were records kept as part of patients' medical records, or were they kept separately?
I think there were two systems of recordings. The main one would be in the patient's notes. Every time a patient received a blood transfusion or transfusion of blood product, the requirement for the doctors writing in the patient's notes, sometimes with the help of the nurses, was to document not just the fact that they'd been transfused, but with the specific donation number of the transfusate. And sometimes accompanied by laboratory forms that were sent back to the ward, including those precise identification markers. So those should have been inserted into the patient's notes every time. Obviously, with a haemophilic receiving lots of treatment, they would have accumulated and got a very thick set of notes, but that was the accepted. So that's what should have happened, and I'm pretty sure it did happen in Liverpool. The other set of records would, of course, be in the laboratories, where there was patient data associated with the laboratory findings, because quite often, not always, but quite often, particularly when covering surgical procedures, the samples were taken for assay. Those assay details were recorded and kept on record in the laboratory files. So those would be less complete, but they would still be records. And I would imagine that after I left Liverpool, those two sets of records still form the principle of data access for subsequent searches.
And what about home treatment records? Were patients or patients' families expected to keep those and return them to the centre?
They were expected to return the, sorry, let me just go back on that. I honestly can't remember exactly what the home therapy patients in Liverpool what instructions they received about disposing of the waste materials, the products and the needles, etc. I think this would be the days before sin bins, so they were still instructed to take care about the disposal of the needles. And that goes back to my previous recollection, that I think that the people who were doing home therapy were certainly advised to take care about the disposal of the waste products. batch numbers of all the materials they were given should have been recorded in the patient's notes. Whether that was the case or not, I cannot honestly answer, but they should have been recorded in the patient's notes. And that would have been the main record, because the ward would have had a refrigerator where these materials were kept. So although they came from the blood bank, and the blood bank would have also kept details of the batch numbers, the ward would have been able to identify those that they were giving to the patient. So ideally, there should have been a record of the batch numbers on every bottle of factor VIII concentrate that was given. But I honestly cannot recollect the details of how that system worked.
Can we look at a document? There's HCDO 301093. It's a document we've already looked at. It's the 1977 returns. And Zali, can we go to page 3 of that document, please? This is a letter from you to Miss Spooner at the Oxford Hemophilia Centre, dated the 23rd of September 1977. And you say this at paragraph 1. I recall rather shamefacedly that when I saw you in Oxford on the day of Dr. Biggs's retirement, I promised to send you our annual return at the earliest opportunity. All I can say is that the final compilation has not been quite so easy, as some of our medical records have the annoying habit of going missing just when they are wanted. And then the next paragraph you say, however, this is the best I can offer you at this stage. As you will remember from a telephone call some months ago, I feel that I'm not able to take part in Dr. Kirk's jaundice survey. And this is a bit regrettable, as 2 of our patients have had some form of hepatitis during 1976 to 77. And then you say, I'd like to amplify a bit on those 2 cases. And then you refer to one case. It's just the first part of that in relation to records that I want to draw your attention to. Say the man was treated with a batch of cryobulan to cover a vasectomy, but unfortunately the doctors who withdrew the material failed to observe the departmental rule of the registration of batch numbers, etc. This has been a salutary lesson to me, and I've tightened up our recording procedures. But I must comment that with the best will in the world, little can be done about doctors who fail to observe the rules. So just pausing there then, there seem to have been 2 problems that you've identified in this letter. First of all, problems with the recording procedures, which you've just told us about, and having to tighten up the rules. And at the beginning of that letter, the records have an annoying habit of going missing. This letter might give an impression of a somewhat chaotic recording and record-making system at Liverpool during 75, at the time you were there. Is that a fair conclusion to draw from this letter?
I think it's fair in one sense that it was highly undesirable, but this is not a unique experience, particularly for patients who were regular attendants at the clinics and the wards. They would go missing in transit. So the wards had their record collections. The outpatient clinic would require those records to be available to me when I saw the patients. And after I saw the patients and had made my extra notes, I would put them on one side for them to be returned to the ward when possible. There's the best will in the world. Sometimes it will be some days or even occasionally weeks when the records were not locatable with any great ease. I think that was a day-to-day experience in many hospitals up and down the country in many specialties. So it wasn't a unique. It's fair to comment on the chaos that surrounded that particular system, but I am sure this was not a unique experience. One of those that we sort of shrugged our shoulders and got on with. It was difficult. It made life difficult to make accurate records at the appropriate time. and therefore would prejudice the quality of those records. But these are busy hospitals with regular recurring patients and ever-growing notes, and finding pages missing in the notes was all much more difficult. That's the problem with paper records. Similarly with donor records, when computerized systems became available, theoretically, they should have been much more accessible through local devices. But those were the days of intensive paperwork and depended upon the commitment of those who were working and writing the notes and keeping them as to how they would be used and made available to others. So it was a sort of standard expectation, but and it was chaotic, but I think not more chaotic than was often found throughout the health services.
I'm going to move on now to ask you some questions about your time in Edinburgh. So just to remind ourselves of the chronology, we're now in 1980, and you spent 10 years in Edinburgh, first of all as a consultant, and then in 1982 as the Deputy Director of the Edinburgh Centre, Edinburgh and South East Scotland Centre. Now, we've heard oral evidence from both Dr. Gillen and Dr. Brian McClelland, who have covered some of the issues and events during the time that you were there. So I'm going to just pick up some specific issues with you rather than run through all of the matters that are set out in your witness statement. First of all, I'm going to ask you some questions about the centre itself and the role that it had. You described to the Penrose inquiry the South East Scottish Transfusion Centre being a transfusion centre that also had an active clinical base. What did you mean by that?
One of the reasons why I was attracted to the Edinburgh Post was that, unlike the standard system in England, where you have a regional transfusion centre that is separate from the hospital activities, sometimes in the same grounds of the hospital, but actually organised as a separate unit, and sometimes quite remote from the working hospitals. So the transfusion centre would be solely concerned with the collection and testing of blood donations. There would be reference laboratories that would do the specialist investigations, mostly on rare blood group types for suitability for transfusion to patients. So the patient contact was much less from the English centres. And I think that, well, in fact, I know the same really occurred at Glasgow when the centre was at Law Hospital, which is like 20 miles away from the main Glasgow hospitals. Whereas in Edinburgh and the other centres in the east of Scotland, the centre was not only within the geographic hospital, but also directly issued blood for patients who were identified cross-matched in the labs of the transfusion centre and not in the labs of the haematology laboratories, which is the case in most other hospitals. But furthermore, in the Edinburgh Centre, there was a laboratory for hemostasis and blood counts. Blood counts were standard in transfusion centres. Of course, we needed to have some sort of investigation into the donors who were anemic. So we were able to do blood counts. But in Edinburgh, not only were we able to do blood counts, we could do platelet counts on donors, and we could do also clotting factor assays on donor plasma. Also, this laboratory was available, serviced the hospitals, and particularly the Royal Infirmary, for patients who had acquired bleeding disorders or thrombotic disorders as a result of an acquired condition, often surgery or some other illness, including liver failure. And so we were able to investigate those patients. So there was a rather greater availability to the hospital clinicians of investigations, laboratory investigations for patients conducted in the transfusion center, which in other places would have been conducted in the hematology laboratories. I was given that responsibility for the clinical advice from that extra laboratory, and particularly for the clotting factors associated with patients, because it wasn't just hemophilics who had abnormalities and clotting factors. So although Christopher's laboratory would also have been able to, and did, the assays of factor VIII and the clotting investigations, particularly on the hemophilics, there was a sort of competition between the two, and I wouldn't blame Christopher at all if he felt that we were intruding on his territory. But for me, that was one of the reasons I came up. I was advised by Dr. Cash when I came that this facility was available, and I found it very attractive. It enabled me, for example, to participate actively in audits around the hospital of blood usage, and particularly useful, and I think this has also been commented by others, for the cardiac surgery. When I arrived, the cardiac surgeons basically wanted 10 pints of fresh blood for every open heart surgery operation they conducted. By the time I left, partly due to my work, but also partly due to increasing awareness among the surgeons, and particularly the anaesthetists, the use of blood was much more rational, much more use of red cell concentrate, and much less emphasis on the freshness of the blood, which actually caused quite a hurdle in the provision services, because it does take time when a transfusion center has received the blood from the donor to get it tested and suitable for transmission. Usually 2 days at least between receipt and availability for issue, and the virtue of the freshness of the blood would disappear within those 2 days, according to the surgeons. And there was some justification for that particular thinking. But as a result of my close contact with the clinicians, physicians, and particularly surgeons, we were able to develop an audit system, and that was all to the good of the standard of practice within the hospital. But that explains a little bit sometimes of the interactions between Christopher and myself that went on. Christopher was also very busy looking after other patients. Again, for him, only part of his service was to do with hemophilia, although it was a very important, and he was very committed to that. But we were both busy doctors doing other things, but ultimately very committed to high quality standard patient care. And I, having left Liverpool, knew that I was deserting, if you like, the haemophilics thereabout, which I felt quite bad, not least because I never had to face up to the difficult conversations with those haemophilics and their families in the 1980s. And I felt bad about that. But I was therefore an experienced haemophilia doctor in the hospital, but I did take care to intrude minimally on Christopher's practice. It was his job, and I had a different job, and I think I said that to the Penrose, so that we respected each other's interests and commitments, and indeed what we were expected to do. But there were times when we had to have open, friendly, frank conversations about how we actually approached a particular deal. And that came particularly to the fore when it came to assaying haemophilics who were receiving the new heat-treated products to see how effective they were, not just clinically, but also by the lab tests. And so there was a real need for Christopher and I to work together, as well as the need to work together on ensuring he got adequate supplies for his own expanding home therapy program.
And Dr. Boulton will come on to look at some of those issues that you have just told us about in a little bit more detail, perhaps by reference to some documents. But just picking up then on the work done by the centre, Did the centre do ALT or AST testing of people with bleeding disorders?
No, I don't think we did. Just as in Liverpool, the Edinburgh Centre would have referred those samples to the local laboratories in clinical chemistry, I think, for those particular determinations. So I don't think we had a lab in the centre that would do those tests.
And what about white cell or immunological testing?
Well, we were a immunohematological unit. Blood transfusion is sometimes described as immunohematology. So I'm not quite sure what you mean about what you're referring to.
It's a question I've been asked to ask you. So perhaps perhaps I can get some more detail.
Well, we were doing tissue types for patients in relation to the organ transplantation. We were looking at lymphocyte subtypes. That was part of the immunological aspects of the work of the centre. So we were pretty thoroughly involved in immunohematological investigations.
We heard evidence yesterday from, we'll come back to some of those issues, but just before we do, we heard evidence yesterday from Dr. Gabra, who said that in Glasgow they were heating plasma over many years, and he thought that the same was happening in Edinburgh. Do you have any, can you assist us with whether that was taking place in Edinburgh or, to your knowledge, in Glasgow?
I didn't know about the heating of plasmas in Glasgow. We didn't do any heating of plasmas in Edinburgh. What was going on in Glasgow, which was intriguing, was that they were freeze-drying units of cryoprecipitate. In other words, they were exposing donations of plasma collected that were decanted into bottles and treating it in a freeze dryer in a way analogous to that which was developed at the Protein Fractionation Centre for freeze drying the fractionated concentrates. So Glasgow was keen and had been doing for a long time freeze drying of plasmas, and they extended it in the, I believe, in the 1970s to the freeze drying of cryoprecipitate. I think the idea there would be that we could have bottles of cryoprecipitate that instead of expiring within hours, unless it was deep frozen, these were cryoprecipitate preparations that could be stored for months or years and then reconstituted in a few minutes by adding water in the same way that the factorate concentrates were being reconstituted. So those were being prepared from the Glasgow Centre. They may have been heated, I just don't know. My understanding is that sadly, the freeze-drying apparatus in Glasgow, which was of Second World War time vintage, by the 1970s, had failed the standards of good manufacturing practice required by the Medicines Inspectorate. So consequently, the process of making and distributing freeze-dried cryoprecipitate for the use of haemophilics within Scotland or even in Glasgow, I think it never really got off the ground in the way that the Glasgow Centre directors hoped. But that was certainly a valid aspiration, and it was worth trying to do. But as what happened in Edinburgh, of course, is the Protein Fractionation Centre originated in the Royal Infirmary, moved out to Liberton Hospital sometime in the mid-1970s, and took with them the equipment, including the freeze dryer. So the Edinburgh Centre was never in the position itself of freeze drying plasma or cryoprecipitate in quite the same way that Glasgow was hoping to do.
I'm going to pick up now on some of the points you mentioned earlier in terms of consultation and a discussion with your clinical colleagues about use of blood and so on, and the audit. of the use of blood. We've heard from other witnesses the use of blood ordering schedules. Is that a practice that was used in Edinburgh?
Yeah, yes, we did. We developed the MBSOS, and that was developed in quite some strength.
And you have made reference to having various relationships with clinical colleagues. Was the audit and the training and discussions that you were having limited to those colleagues in the Edinburgh Royal Infirmary, or was that work you did throughout the whole area covered by the Edinburgh and South East Scotland Centre?
Well, I understand what you're saying, because just to clarify, which I think you already got, the blood bank provided by the Edinburgh Blood Transfusion Centre, cited in the main Royal Infirmary, also supplied blood to small peripheral hospitals that have long since closed, the LC Ingalls, the Bruntsfield Hospital, and others that scattered around Edinburgh that had an interesting history providing specific services, Bruntsfield for women in particular, for example. So only about 70% of the blood which we distributed to the Edinburgh hospitals was distributed to the Royal Infirmary. There was the other major hospital in Edinburgh called the Western General Hospital, which was also staffed by hematologists, excellent hematologists, Dr. Norman Allen, who had their own blood bank. And so we would supply the blood to them, but they did the cross-matching. They did not treat, as far as I'm aware, any haemophilics at all. That was specifically for us in the Royal. But that hospital was a significant user of blood, and they would have been drawing up their own blood ordering schedules. Similarly, for the more remote hospitals in Melrose and in Livingston in West Lothian. So consequently, and also I think in the Kirkcaldy hospitals, because I think I forgot to say, but the others would have said, that the Edinburgh Centre also distributed blood to hospitals in the south of Fife, across the Forth. So consequently, although we in Edinburgh were cross-matching blood for mostly for although the blood we distributed went to several other hospitals, most of it went to the Royal Infirmary, but the Royal Infirmary also had its satellite hospitals, and our efforts on blood ordering schedules would have been concentrated mostly on the practitioners in the Edinburgh Royal Infirmary. That, of course, was facilitated considerably when the realignment of hospitals to the new Royal Infirmary occurred somewhat after my time. But yes, we were doing the services, we were doing it for surgeons and for some of the physicians as well, but it became to be more expanded as the services within Edinburgh also got modified with the new hospital buildings.
I'm going to come on to ask you some questions about your role in terms of procuring PFC concentrate for Dr. Ludlam in the Edinburgh Hemophilia Centre, and discussions with him about the use and prescribing of that. But I'm now going to ask you some questions about, and you've already touched on this in your answers earlier, about your role and your input with those people with haemophilia being treated at the Hemophilia Centre in Edinburgh. We heard evidence from Dr. Brian McClelland, who told us that it was his impression or his view that those patients were, and to use his phrase, jealously guarded by Dr. Ludlam, and that you didn't have a chance to have any direct dealings with them. Is that correct, as a matter of fact, that you didn't have face-to-face dealings with the patients being treated in the Edinburgh Hemophilia Centre?
Brian was immensely supportive of me. He was a great colleague. So consequently, he would have been prepared to sort of defend me in those sort of, in any of those sort of situations. I'm not sure I would use the words jealously guarded. I mean, Christopher did allow me to speak to his patients at one meeting of a Hemophilia Society gathering there. I was well known to the laboratory scientists in his department, and that included in the hemophilia laboratories. They knew me. We also knew some of the, were working with some of the senior registrars who actually rotated through the blood transfusion center. So it's not as if there was a brick wall between us. The departments were next door neighbors, so it was inevitable that there'd be some informal, quite a lot of informal contact. So yes, there was, Christopher was very keen to make it clear that he was the one who is now running the Hemophilia Center. I had no difficulty with that. He had every right to expect that, and also to expect the manager. I would say, oh, I think you got that a bit wrong. And Christopher and I met within 2 weeks. We were both new, and I knew that he was wanting to expand his home therapy program. I was fully supportive of that and always was. As time went on, within 2 or 3 years, the expanding program caused stresses on the supply. So I was called in to advise Christopher. I think the words in my letters were warn, which is a bit unfortunate. I think it would have been better to use the words inform and advise. But basically, I needed to clear with Christopher the degree of how the transfusion service, and particularly how PFC could best respond to his requirements. So it did require a regular set of meetings, and we had them, and some of them are documented, and the correspondence surrounding them are documented in the inquiry's files. So we developed a working relationship, which I think worked well for him, and particularly, even more importantly, for the hemophilics. Some tragically developed inhibitors, others tragically developed hepatitis, others developed AIDS, and that was awful. And I think you've gone through that episode in November 1984, when, to our horror in the transfusion services, and also Christopher's own horror, a batch of PFC factor VIII concentrate was contaminated with the HIV virus and transmitted it to, I think, at least 16 or even 17 patients, and one or two possibly in Glasgow. So that was, and it may, whether it's one donor or 2 or 3, we never quite got round to, but it was probably a very small number of donors over those years, giving hundreds of thousands of donations, who infected that batch. An absolute tragedy, and we never quite got to the bottom of how that transpired, but it was awful for us, for Christopher, and in particular for the patients. So that degree of cross-communication was vital. I was under a bit of a disadvantage, which Brian did his best to alleviate, in that there were meetings between Christopher and the transfusion directors from which I didn't attend. And I understood that. Brian briefed me as much as he could about those meetings. Otherwise, I couldn't have done my job. But it was a little bit of a barrier from that side. But it wasn't as if the transfusion centres meetings were jealously guarded. But even less so did I think that jealously guarding is really the best way of describing Christopher's attitudes. He and I needed to work together. We both recognized that. And yes, it caused, a little bit of blood pressure raising occasionally in the way that these conversations do, but it was a dialogue, it was not a debate. And so consequently, we, on the whole, got on amicably. And I would still say that if I were to meet Christopher again today, and I don't quite know when I last met him, we would be on the best of friend terms. So that's the sort of memory that I've got, and that's how I think we behaved at the time. But it was not always easy, I do have to say.
So just picking up then on the role that you played between with the Hemophilia Centre director, Hemophilia Centre. We'll look at some of the correspondence, but would it be fair to say that you were doing two things really? On the one hand, you were providing Dr. Ludlam with the PFC product, the factor 8 product from PFC that he wanted, and sometimes having to borrow and beg it from other areas because he'd exceeded what you'd already given him. And at the same time telling him, or you use the word warning, or whatever the correct word is, telling him, warning him, reminding him to prescribe within the Edinburgh, the Southeast Scottish Regional Transfusion Centre's allocation of PFC product.
I think that's correct, yes. And I think the correspondence speaks for itself.
And so in a sense, you are almost carrying out a coordinating role between, on the one hand, PFC, and on the other, the Edinburgh Hemophilia Centre, and there's you representing the South East Scotland Regional Transfusion Centre and or the SNBTS in the middle, coordinating between those two.
Yes, and the most valuable part of that coordination was the trialling of the various heat-treated products from PFC to see how effective they were, both clinically and with regard to the testing. And apart from the one episode, which we may not need to refer to, when there was a misunderstanding, that was carried out with cordiality, cooperation, not least from the patients who needed lots of needlings to get the samples, and that was, in my opinion, highly successful and very satisfactory work to actually be able to demonstrate that these materials were actually working. We were not able really to test how safe they were hepatitis-wise or HIV-wise, apart from the in vitro tests on those materials to see how well they were at inactivating viruses. So part of those trials did not really include a detailed study of their liver function. It was more directed towards their hemostatic functions, and that was carried out in some detail with schedules that Christopher helped me draw up. So this was collaborative work of a very satisfying nature.
And we see you being appointed or taking on the role of coordinator of some of those research or clinical investigations. And
not just with Christopher, but with outsiders such as Dr. Main in Belfast and indeed Dr. Bloom in Cardiff.
So I'm about to look on the same topic, but look at a couple of documents, and I note the time. I don't know whether it's appropriate to continue now for which will take us probably till 5 past or possibly even 10 past 1, or to take a break now.
Well, let's take a break now and come back at 2 o'clock. So 2 o'clock.
Thank you.